أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Uh, After a break of few months, it's my honor to uh, speak to my dear students on online. And today, a topic of discussion is really very important in both academic point of view as well as in reference to clinical discussion. The topic of today's discussion is short stature, and you second my suggestion that including me and many of the my audience, they were having a problem. They were concerned about their own stature in the early life, uh, in their uh, school age and in their adolescent age. Sometime this short stature may put you uh, as a source of embarrassment, but anyhow, with the passage of time, most of the sufferer, most of the victim of short stature, they come out of that problem, and that is a part of a normal growth, what we called as constitutional short stature. And in the subsequent discussion, I will put more time on these aspects, that most of the sufferer, most of the victim of short stature, they are actually not a patient of short stature, but it's the part of their normal slow growth in the early years of life. But anyhow, in next 25-30 minutes, my focus of discussion will be to share some of the definitions related with short stature. What are the common as well as less common causes of short stature, and how we should approach when we come across, when we interact with a child whose parents or whose patient himself is concerned about short stature. And last but not least, what is the management of constitutional as well as pathological short stature. Most important thing is that why we are so much concerned about short stature. Yes, on the one hand, it may be a sign of disease, a sign of a, pathological process that may end up in the form of a disability, but above all, for most of the sufferer of short stature, it's a social stigma. You have commonly heard the name given to these short normal babies: Gittu, Pidda, Teddy, uh, as well as so many other names given to these children, and this stigma carry on for many years to these babies until and unless they come out of this problem between 10-15 years of their age. By definition, we call short stature really short when when the height of a baby is less than 2 standard deviation for his or her age. You can appreciate that the 2 standard deviation is the lowermost limit of a normal range of that age. So whenever the height is persistently lower than 2 standard deviation, then and only then we can call a patient that he is a patient of short stature. So there is another way of defining short stature, that if we monitor a patient, monitor a baby who is persistently below 25th percentile for many months if we regularly monitor the height of the patient for some 6 to 12 months, and the height of that baby is persistently below 25th percentile, one can label that child he is a patient with short stature. Currently, there is no room for the application of terms like dwarfism and failure to thrive, in which weight and height, due to any reason, is less than uh, findings for that age. We can label, we can group as a secondary cause of short stature, and that is really not the domain of discussion in these patients. If we review the normal physiology, the growth of the baby is interplay of multiple factors. Although the major factor is related to genetic factor, that what sort of height potential that baby is carrying from his or her father and mother, that genetic potential of height is influenced by a number of factors like comfortable environment around the baby or a stressful environment around that patient baby. He is deficient of calories, or he is being provided adequate amount of first class proteins as well as macro and micronutrient with a balanced diet. And above all, there is a remarkable influence of number of hormones, especially growth hormone, thyroid hormone, and gonadotropin in the form of TSH and LSH, estrogen and progesterone. So many other hormones related to pubertal growth spurt, they have a major role in determining the growth or height of ultimate height of that baby. The interplay of these different factors will be easy to understand if you uh, mm, if you have a look on this picture representation. Before delivery, intrauterine problems like nutrition of the mother, like infections of the mother, they have an impact on the growth of the patient, and a baby may be born small for gestational age, even with full-term pregnancy. And in the first year of life, the two important factors which determine the growth of the patients are the adequate provision of nutrition as well as thyroid hormone. While second month till the onset of puberty, the only hormone which has a major impact is the growth hormone. While as the puberty set on between 10 to 14, 15 years of age, then there is impact of these gonadotropins in the form of SSH, LH, as well as the effect of growth hormone, thyroid hormone that continue till the completion of growth around 15 to 16 years of age. If we have a look uh, in this simple diagram, there is important message in it that a baby who is born with the length of 50 centimeter, there are few areas of rapid growth, what we call as growth spur. The first rapid growth is in the first year of life, in which baby has a gain of 25 centimeter and a 50 centimeter uh, length baby at the end of or at the uh, time of his first birthday. He has grown up to 75 centimeter, which is the uh, uh, most rapid time of growth velocity. uh, then in the second year there is a gain of about 12-13 centimeter, and a 4-year-old baby has a standard height of 100 centimeter. Subsequently, for a couple of years till the onset of puberty, there is a growth of 6 centimeter, 4 to 6 centimeter every year, and a 12-year-old baby has a height of 150 centimeter till there is another uh, another period of rapid growth, what we call as pubertal growth spur, in which around 10 inches or 25 centimeter height is gained by a boy or girl. So, for normal growth, we have to determine the growth velocity. For every 3 to 4 monthly, we keep on recording the height of the patient, and then after 2 to 4 readings, one is able to determine that what is the growth velocity, how many centimeter in a year baby is growing. The issue is when a babies keep on growing at a same graphic representation, that same line of growth, that doesn't matter. But if a baby try to cross the percentile lines of his growth, that makes us alert. Either it is going up on or it is going downward. Both are very important to follow in reference to their workup and determining the cause of deviation from normal growth. Before moving on to history and examination, one should uh, be able to have a good input into growth, into history and examination, if we are well aware of the different causes of short stature. Practically, if we want to enumerate different causes of short stature, we have to subgroup our patients into two categories. One is proportionate short stature and second is disproportionate short stature. Proportionate short stature is one in which both limbs as well as spine of the patient is short. So a baby is as a whole is short, both limb and spines, they have a decreased potential in reference to growth. If and If we further subgroup this proportionate short stature, that may be normal, what we call as familial and constitutional growth delay, which is the cause of major bulk, which is the major group out of these short stature patients, that is a normal variant. While sometimes there may be some prenatal factors are operating, like intrauterine growth retardation, as I mentioned earlier on, that torch infections or intrauterine infections and some sort of teratogens in the form of toxins, they have a bad impact on the growth potential of these children, and they continue that impact even after delivery. So the impact of intrauterine stress may end up with short stature. Similarly, if a patient is thriving in an uncomfortable environment in the form of emotional deprivation in reference to different psychological stress from the parents and from the uh, caregiver, uh, these patients, they also have a bad impact on their ultimate growth potential. And number of endocrine causes which has a proportionate short stature, like growth hormone deficiency or a chronic type of diabetes mellitus, similarly adrenal problems like Cushing's or Addison, these patients, they also have proportionate short stature. While the second group of short stature, which I mentioned, is that these patients, they have either problem with the growth of spine or growth of the limb. So one is normal, either spine is normal and limbs are defective, or limbs are normal or and spine is defective. So if the limbs are at fault in reference to growth, these patients they have short limb dwarf, and you are commonly encountering in your common day practice patient with achondroplasia, short arms and short legs, but the spine and head size is within normal size. While in patient with short trunk, that is where the defect is in the spine, these patients they have what we call as spondyloepiphyseal dysplasia. The length and growth potential of their limb is normal, but spine is of significantly short size. So, if we approach clinically to a patient who present us in the OPD, outpatient clinic, has a short stature, we have to determine that uh, on physical examination he is normal or he is a dysmorphic child. Dysmorphic means that his facial appearance, his different appearance of the eyes, appearance of the nose, ears, or as well as limbs, they have uh, abnormal appearance. So in that patients, there are number of syndromes which have different uh, abnormal morphology of their face, eyes, ears, as well as limbs. That includes commonly like Down syndrome, like Turner syndromes, as well as Noonan Silver Russell syndrome. They are dysmorphic as well as patients of short stature. While those patients who has normal facial appearance, no any dysmorphic feature, but they are short, and then in that group we subdivide into what we earlier on discussed as proportionate short stature or disproportionate short stature, and already we have discussed the causes which are grouped under the heading of proportionate as well as disproportionate short stature. Another way of approaching to a patient with short stature is that what is the target height. One is able to determine from the height and weight of the father and mother. One can calculate that at the age of 17 and 18 years of age, what will be the growth potential, what will the ultimate or target height of that patient. So if there is patient is not within the target height of the patient is less than normal, then we determine their growth velocity. And if the growth velocity is normal, they will be taken as growth delay or the patient will be having low birth weight, while a patient with low growth velocity mean that that patient is a sufferer of some endocrine problem or there is some chromosomal issues in those patients who is having low growth velocity. Uh, Earlier on, I discussed that the major share or major component of the short stature is the normal variant, and that normal variant comprises of familial short stature, or second group is constitutional short stature. There are a few areas which help to differentiate these common causes of short stature. Familial short stature mean that that baby is having a genetic background of a short stature. He will be short. Uh, there is family history of short stature, and ultimate height of that patient will be short. While in constitutional short stature, he will be short for early life till the onset of puberty, but the ultimate height of the patient will be final height of the patient will be normal. The only difference is that uh, patient with constitutional short stature, their onset of puberty is delayed, and the same is the delay in the onset of puberty in their parents as well. While in familial short stature, the puberty will be at the normal age, both in boys and girls. If we determine their bone age by X-ray in patient with familial short stature, bone age will be same as that age in years, what we call as chronological age. Chronological age in familial short stature, both age will be similar, while in constitutional short stature, the bone age will be less than the chronological age, and bone age will be equal to the height age of the patient. So bone age, if a patient is of 8 years, so his or her bone age will be around 5 to 6 years, while in familial short stature, bone age chronological age will be similar. So, and again to mention that patient with familial short stature, their target height will be short, while in patient with constitutional short stature, the ultimate height will be normal. That will help you to understand that in patient with familial short stature, they will be short and they will remain short till they attain their final height. While in patient with constitutional short stature, they will be short, and even at the time of puberty, they will be lacking in their growth. But ultimately, they will catch up, and the final height will be like normal children. So, after a delay in the puberty, they have a catch up of the growth, and the final height will be normal in these patients. So these are the few syndromes which we come across in addition to dysmorphism. They have short stature, like a patient with Turner syndrome who is having a web neck, low hairlines, as well as wide carrying angle in this patient. Primarily, they are monosomy. One of the X chromosome is lacking in this patient. So similarly, many other syndrome in addition to Turner syndrome, like Silver-Russell or uh, like Down syndrome, they have a short stature. Then there is another group of illness which we come across every day in the accident short stature, and this group of illness is that patients who are sufferer or victim of chronic illnesses. That may be chronic infection, that may be chronic GI problem, that may be chronic pulmonary problem. So chronic infection, especially tuberculosis, chronic pyelonephritis, uh, by a composite of different factors, they ultimately end up with short stature. Similarly, patients with chronic diarrhea like IBDs, Crohn's disease, ulcerative colitis, or malabsorption in the form of A beta lipoproteinemia or co-milk allergy, uh, they ultimately have a short stature. But out of malabsorption, the most common illnesses which end up with short stature is gluten sensitivity, or what we call as celiac disease, as well as inflammatory bowel disease. They have a significant impact on their growth potential, and in addition to chronic diarrhea, they have a very obvious short stature. You are well familiar with patients of hypothyroidism with large protruded tongue, coarse facial feature, husky voice, dry hair, as well as umbilical hernia. And in addition to mental retardation, the most pronounced impact on physical examination is on their growth. So they have low IQ as well as short stature. Similarly, Cushing syndrome or many of the related growth hormone problem or in disorders of estrogen and progesterone, they, in addition to short stature, they may be having obesity, they may have the problem in the form of pigmentation or hypertension, so many other manifestations of these different type of adrenogenital syndromes, but the most important effect is on their growth potential and manifest as short stature. So achondroplasia, chondrodysplasia, so different forms of skeletal dysplasia, they are also sufferer of short stature. So whenever with this different causes of short stature, when we have to approach a baby who present with short stature, so we have to move with detailed history, and in the history we focus on different points like what was the uh, if we inquire about from the parents and from the baby, these are so many points which help us to clinch the cause and to develop our good history of a patient who presents with short stature. So most important question is the time of onset of puberty in the father and mother. Then what was the status of child at the time of birth? He was of normal weight or he was small for gestational age? Is he was sufferer of any jaundice or hypoglycemia? What sort of nutritional history was gathered in the form of adequate nutrition or undernutrition? A urinary problem in the form of polyuria reflect on diabetes. Similarly, history of loose motions or diarrhea help to find the underlying problem of short stature in the form of celiac disease or other type of malabsorption syndrome. Similarly, uh, there are other issues like in the form of rickets, in the form of wrist or spinal problems or bowing of the legs. Similarly, cardiac problems in the form of congenital heart. So many findings on physical examination help us to understand that what is the likely cause of short stature and how we should approach when we are going to work up our patient with short stature. So before investigation, the most important thing is that one is able to determine the proper height of the patient. Before 2 years of age, we have to find the length with the help of infantometer, while after 2 years of age, one should measure the height with the help of Herpendon stadiometry, which is the standard way of determining the height in children. So these are the guidelines whenever we have to find the length of a child. So the good thing is that child should be relaxed. He has appropriate uh, position of the head and legs before determining the height of these patients. And when we have to find the standing height, uh, as depicted in the picture, that heel, buttocks, shoulder as well as occiput of the patient, they should be in touch with the uh, height scale, and we should able to uh, appropriately our position as well as the bar which is at the top end of the head, there should be firm, not a flexible one. So appropriate a hard surface should be placed on the top, as well as heel, buttocks, shoulder and occiput should be in close contact with the wall or uh, height scale. Then another important is it's a very uh, 1,000 years old picture uh, in which uh, the impact of different uh, segments of the body was appreciated, but currently we subdivide the body proportions into upper and lower segment, not from the umbilicus but from the pubic symphysis to the ground, and from the pubic symphysis above is taken as upper segment, and from pubic symphysis to the ground that is taken as lower segment. Uh, mm, this subdivision of upper and lower segment help us to understand what we earlier on discussed in reference to proportionate and disproportionate. A problem with the spinal growth, they have a defective growth of the upper segment, and problems of the with the limb growth, they have a short lower segment. So with this, I conclude my presentation with the uh, dua that long live Pakistan, और मेरी अर्ज़ पाक पे वो उतरे फसले गुल जिसे अंदेशा है जिसे हज़ां का अंदेशा ना हो. So thank you very much for patient listening. And before concluding, my request is that you review these MCQs and submit your response of these two MCQs after having a view of this uh, video presentation on short stature, and I will appreciate your response if you're able to understand, if you have a able to solve these MCQs. That will make you to understand that you have appreciated the topic of short stature. So thank you very much once again for patient listening.